Let's talk about the elements of the enhanced CAUTI prevention bundle. The first element of the bundle is to avoid unnecessary urinary catheterization. Indwelling urinary catheter insertion should be performed only per the standard list of indications, and this include acute urinary retention or obstruction, epidural anesthesia or analgesia, open sacral or perineal wounds in incontinent patients, perioperative use for selected surgical procedure, prolonged immobilization such as spinal precautions or trauma, to improve comfort at the end of life, and lastly, urinary output monitoring in the critically ill patient. The second element of the bundle involves considering alternatives for indwelling urinary catheter. Before placing an indwelling catheter, consider if these alternatives would be more appropriate, such as using the bedside commode, using the urinal, or using incontinence garments. We can also consider using the male external catheter, the Purewick urine collection system, or the male urinary pouch. The portable bladder scanner can also be used to assess and confirm urinary retention to reduce unnecessary catheterization. It is a non-invasive way to determine the volume of urine remaining in the bladder after voiding to inform whether a urinary catheter is needed. A straight catheter can also be used for one-time, intermittent, or chronic voiding needs. It is most often used in patients with neurogenic bladder or spinal cord injury and lessens the risk of urinary tract infection compared to chronic indwelling urinary catheters. The third element of the CAUTI prevention bundle involves inserting the urinary catheter using a septic technique. To do this, we have to take the following steps. First, before indwelling catheter insertion, perform perineal care using an entity-approved cleaning agent. Next, we have to perform hand hygiene before and after urinary catheter insertion. Third, we have to perform the urinary catheter insertion using a sterile technique with cross-monitoring by another licensed practitioner. Fourth, we have to ensure proper securing device to prevent movement and urethral traction. And lastly, if 2 attempts of insertion are unsuccessful, find a more experienced RN to attempt a maximum of 2 more insertions, and if unsuccessful on the 4th attempt, call the provider for further orders. And we have to remember that for the third element, we use 2-person insertion as the second person monitors and helps maintain sterility of the entire procedure. The fourth element of the CAUTI prevention bundle is to maintain a closed urine collection system. First, we should keep the drainage bag tubing off the floor. The proper handling and placement of the drainage bag and the tubing helps prevent contamination and portal of entry for microorganisms. Second, we should not disconnect the drainage bag, and we must ensure to keep the red seal intact. Keeping the red seal intact helps maintain a closed urine collection system, and we can access the needleless sampling port for urine collection. The fifth element of the enhanced CAUTI prevention bundle is to ensure unobstructed urine flow. And to do this, we have to keep the drainage bag below the level of the bladder. This will help keep urine from flowing back into the bladder. Next, we also have to avoid dependent loops. Dependent loops in the urine drainage system can generate back pressure on the bladder that interferes with bladder emptying. To help ensure unobstructed urine flow, we also have to secure tubing to the body with a securement device. Using a securement device prevents the urinary catheter or its retention balloon from causing injury or damage to the skin, bladder neck, or the urethra. And we have to empty the drainage bag before transporting the patient off the unit. Emptying the drainage bag prior to transporting a patient can help avoid urine reflux. And we have to check prior to transport if our patient's urinary drainage bag is good to go or not good to go. And a rule of thumb to remember this is empty or low or you don't go. The sixth element of our enhanced CAUTI prevention bundle involves implementing an improved approach to perineal care. As per our clinical guidelines, we will use Easy Cleanse disposable washcloths for cleaning the perineum, urethral meatus, and the urinary catheter. We will also perform perineal care and catheter care with daily baths and after diarrhea or stool incontinence episodes. And we always have to clean the perineum front to back. As per our guidelines, we'll perform daily CHG bathing with the hospital-approved CHG product and perform catheter care with Easy Cleanse disposable washcloths plus CHG. As an added layer of our improved approach to perineal care, we will now be using the perineal irrigation bottle on patients with indwelling urinary catheters and suffering from diarrhea or stool incontinence. The use of the perineal irrigation bottle will promote the mechanical removal of stool and fecal materials through the use of water, and this will help facilitate the thorough cleansing of the peri-urethral area. To use the peri-irrigation bottle, we should fill it with water only. Do not add soap or any other product. We should lift the top and turn to activate and regulate the flow. Use the bottle stream from front to back and discard it after 24 hours or if it becomes soiled. A word of caution though, we should ensure no contact of the bottle with the patient's skin at any time. The seventh element of our CAUTI prevention bundle is the daily review of catheter necessity and prompt removal if possible. Assess each patient for every shift for altered urinary function. Evaluate the continued need for an indwelling urinary catheter every shift. And consult the provider for pre-hospital indwelling urinary catheter indication, continuation, replacement, and removal. When the patient does not meet the criteria for an indwelling urinary catheter, the RN will remove the urinary catheter, document the time of removal in the electronic medical record, initiate interventions outlined in the bladder management and straight catheterization protocol, and assess the patient's ability to void and initiate interventions to encourage spontaneous voiding. For our reference, this is our nurse-directed bladder management and straight catheterization protocol.